A 68-year-old man comes to the office due to weak urinary stream, hesitancy, and straining on micturition. These symptoms have been present for the past 2 years but have gradually become more severe and are beginning to affect his quality of life. The patient started noticing urine leakage, nocturia, frequent urination, and urgency. He has no other medical problems and takes no medications. The patient does not use tobacco or alcohol. He is a business management consultant and a motivational speaker. Vital signs are normal. BMI is 27 kilograms per meter square, which is high. And patient's kidneys are most likely to demonstrate which of the following findings. So, he has weak urinary stream, hesitancy, and straining on micturition. And he also has continuous urine leakage, nocturia, and frequent urination. Frequent urination and urgency. And his BMI is also very high, which means that he is obese. Which of the kidney findings will be there? Weak urine, hesitancy, and straining. So also his age is like 68, so maybe he has BPH. But BPH is usually in men above 75. So yeah, maybe he has BPH, I think. So the first option is glomerular sclerosis and halitosis. Second is hyperplastic arteriolar changes. Third is ischemic tubular necrosis. Fourth is parenchymal pressure atrophy. And fifth is tubular epithelial dysplasia. So I think kidneys are going to be glomerular sclerosis and halitosis. No. Yeah, it is parenchymal pressure atrophy. I thought so because there is back pressure due to BPH. Yes, the answer is right. It is BPH, which has weak urinary stream, intermittency, incomplete emptying, hesitancy, and straining to void. Storage symptoms will be there like FUNI, FUNI, frequency, urgency, nocturia, and incontinence. So this patient has BPH, and as the prostate enlarges, it impinges on the prostatic urethra, causing progressively worsening bladder outlet obstruction. So all these symptoms are there, and then it leads to overflow incontinence, in which involuntary urine spillage from overly full bladder is there. Increased hydrostatic force is needed to overcome this obstruction, causing hypertrophy of the bladder wall musculature and dilation of the renal pelvis, calyces, hydronephrosis. And if left untreated, it can cause pressure-induced parenchymal atrophy and eventually chronic kidney disease. And now I will discuss all the options. First option was glomerular sclerosis and halitosis. It is a typical of FSGS and diabetic nephrosclerosis. Next is hyperplastic arteriolar changes. They are seen in malignant hypertension. Third option is ischemic tubular necrosis, which is from decreased renal flow. And patients develop this oliguria, azotemia, and elevated serum creatinine and electrolyte disturbances. Epithelial dysplasia is considered a precursor of malignancy. So yeah, dysplasia is always a precursor to metaplasia. So okay, next question. Researchers conduct a study in animal fetus with circulation similar to that of humans. The fetus is delivered close to term by C-section. Prior to placental separation and initiation of pulmonary respiration, blood samples are simultaneously collected from several different fetal blood vessels. The blood oxygen saturations are measured from each of the samples. They are 71%, 64%, 62%, 55%, and 43%. So sample with the greatest O2 saturation is most likely obtained from which of the following blood vessels? So I think the greatest oxygen saturation will be from the placental vessels in the fetus. And we know that in the case of fetus, greatest oxygen is carried by umbilical vein, first of all vein, and then it goes In the fetus, since there are no lungs, so greatest oxygen will be first umbilical vein, then it goes to the liver, right? And then IVC. I think it has to be IVC, yeah, I'm right. So this in the fetus, first the placenta that carries oxygen, then umbilical vein, and then it goes through the portal vein, and it also goes to IVC and SVC. They carry this. So the most part is this IVC. It carries most of the oxygen saturation is there in the IVC. First in the umbilical vein, then it goes to the IVC. And IVC also has deoxygenated one, it has oxygenated one also. So the part ductus venosus of the IVC carries this oxygenated one. So oxygenated blood from the placenta is delivered to fetus via umbilical vein. Upon entering this abdomen of the fetus, then a portion of this oxygen-rich blood is delivered to the portal vein to supply the liver, while the majority of it is shunted to the ductus venosus to the inferior vena cava. And from there, in the IVC, oxygen-rich blood from the ductus venosus runs alongside a stream of deoxygenated blood returning from the lower body. As the blood from the IVC enters the right atrium, a preferential streaming effect allows the majority of the oxygenated blood to directly pass through the foramen ovale in the left atrium. This oxygen-rich blood delivered to the left atrium proceeds to the left ventricle and out to the aorta, where it is supplied to the brain, myocardium and upper extremities. And deoxygenated blood from the IVC and superior vena cava fills the right atrium and proceeds to the right ventricle. So this oxygen-rich blood, we can see it is the red one. It is going to the brain and upper extremities through the aorta. And deoxygenated blood from all these organs is also entering the right atrium first and then the right ventricle. And then high pulmonary vascular resistance causes most of the blood ejected into the pulmonary trunk to be shunted away from the lungs, while 90% of the deoxygenated blood being shunted through the ductus arteriosus into the aorta. Right? So, yeah. The most highly oxygenated blood in the fetus is carried by umbilical vein, which empties directly into inferior vena cava via the ductus venosus. So next question is, a study is conducted to assess the effectiveness of new medication and X is added to standard hypertensive therapy compared to standard antihypertensive therapy alone for preventing the development of proteinuria in patients recently diagnosed with essential hypertension. So 5 years after the diagnosis, 97 out of the 100 patients on the medication X plus standard antihypertensive therapy regimen have not developed proteinuria, and 90 of the 100 patients on this regimen have not developed proteinuria. According to those results, which of the following represents the approximate number of patients with essential hypertension who need to be treated with medication X to prevent an additional patient from developing proteinuria within 5 years? Need to be treated. So I think it has to be 7. Oh no, it's wrong. So number needed to treat is 1 divided by absolute risk reduction, and the risk of the control is 10 by 100, that is 0.1, and the risk of the treatment is 3 by 100, that is 0.03. So absolute risk reduction is risk of the control minus risk of the treatment, that is 0.1 minus 0.03, that is 0.07, and number needed to treat is 1 divided by 0.07. So this was a really nice tricky question, and all these questions are from my incorrect material. So all these questions I have done incorrect ones. Okay, number needed to treat is 1 divided by absolute risk reduction, and absolute risk reduction is risk of the control minus risk of the treatment. And we always calculate the risk is equal to how many people are dying divided by the total number of patients. Next question is, a 24-year-old woman comes to the office for evaluation of a skin lesion. Physical examination shows 5 mm brown oval macule on her anterior thigh. Biopsy of the lesion shows normal appearing nevus cells clustered in the epidermis, consistent with benign acquired melanocytic nevus. During histological analysis, the patient's epithelial cells are found to each contain a condensed body composed of heavily methylated DNA at the periphery of the nucleus. This portion of the DNA is most likely associated with which of the following genetic findings? So I know this thing, that whenever there is heavily methylated DNA, it is always going to have less expression, that is low transcription activity. I know this. This is the factual question. Okay, so X chromosome inactivation occurs in genotypic females and results in conversion of chromosomal DNA into condensed heterochromatin, that is bar body. Heterochromatin is located at the periphery of the nucleus and composed of heavily methylated DNA and deacetylated histones, causing it to have low level of transcriptional activity. So next is item 5 of 40. A 20-year-old woman comes to office due to blisters around her mouth associated with mild burning sensation. She reports that she has been having frequent recurrence of these lesions, which resolve spontaneously within a few days. She has no medical problems and she does not take any medications, and these are the physical findings. It is determined that the causative agent of this patient's condition remains in a latent stage in the neuronal cell bodies of sensory ganglia. Upon reactivation, the virus is transported to the nerve axon through the nerve axon to the skin. Which of the following process is most likely involved in this transport process leading to the disease occurrence? So yeah, I think it is kinesin. So I'm confused between kinesin and dynein, but I know one thing, that kinesin is involved in anterograde transport, whereas dynein is in the retrograde transport. So yeah, it is kinesin, because this is going to be definitely anterograde transport, which is from the cell body to the axon. Whereas dynein, had it been dynein, then it would have been the case where the transport is from the cell axon to the cell body. So initially dynein is involved, but later, in the later stages, when there is reactivation, then kinesin is involved in that. And since this patient is suffering from reactivation because she has often recurrence of these lesions, so it is reactivation. Now I'll read the rest of the options. Lamins are proteins which form the fibrillar network inside the nuclear envelope. In addition to providing structural support, they also help to organize the genome and regulate the gene transcription. Selectins are a group of cell adhesion molecules that are expressed on the endothelial cells during inflammatory response. So yeah, we have heard about selectins, how they help to bind the leukocytes and adhere them to allow them to exit the blood vessels at the site of inflammation. Spectrin is again important. Protein defects can result in hereditary elliptocytosis and spherocytosis, whereas pimentin is intermediate filament of mesenchymal cell type. Okay, so next question is, a 26-year-old woman, G1P0, at 36 weeks gestation comes to office for a routine prenatal visit. She has had no headaches, changes in the vision, or right upper quadrant pain. But fetal movement is normal. The patient has no chronic medical conditions and her pregnancy has been uncomplicated. Blood pressure today is 150 by 100 millimeters of mercury and the repeat measurement is 154, so it's hardly changed. All the vitals are normal. Urinalysis shows 2+ protein, and this patient's condition is most likely due to decreased activity of which of the following? So we must take this fact in our mind that she is pregnant and her blood pressure is very much increased. So which of these is decreased? So I think endothelin is a vasoconstrictor, right? So this can't be decreased. So the options are endothelin, HCG, prolactin, thromboxane A2, and vascular endothelial growth factor. So I think the decreased one is no. Oh no. It is vascular endothelial growth factor. That is decreased. That is why she has preeclampsia. Okay, this is a case of preeclampsia in which she has, this is the normal pregnancy in which the spiral arteries are there and cytotrophoblast invasion, which is normal, which leads to vessel remodeling and increased placental perfusion. Whereas on the other hand, the preeclampsia patient are going to have abnormal cytotrophoblast invasion and no vessel remodeling. And there is less placental perfusion, which leads to hypoxia. There is increase in anti-angiogenic factors and decrease in pro-angiogenic factors. So they're asking what is decreasing. So pro-angiogenic factors are going to decrease, which leads to widespread maternal endothelial dysfunction, vasospasm, hypertension, and end organ damage. So this patient has preeclampsia. So preeclampsia, I'm going to write that in my notes that, okay, yeah, this concept is weak of mine. Preeclampsia is defined as new onset hypertension during pregnancy. The blood pressure is going to be more than equal to 140/90 with proteinuria and signs of end organ damage. So she has proteinuria, right? She has 2 plus proteinuria. And or. So signs of end organ damage may be there, may not be there. That is not a compulsion. So she is not having headache.